Well, good afternoon, and may I add my thanks to Klaus and to Morris for this fantastic meeting and for the invitation to be here again. It's a great pleasure to be able to tell you about a randomized controlled trial. As you know, this is not something that we have been known for in orthopedic surgery, but I believe that we involved in hip preservation are really at the forefront of collecting evidence in orthopedic surgery. And perhaps that's as it should be, given that this is a new field. So a few years ago in the UK, the Department of Health was very concerned about hip arthroscopy. They said it's a new cost, it seems to be getting bigger and bigger, costing us more and more money, and it's not clear that hip arthroscopy does any good for patients. And in particular, there's no level 1 evidence, no randomized controlled trial evidence that surgery is effective in these patients. Now that was important because given that there is less and less money available for the health service, the public health service in the UK, more and more the people in charge of spending the money ask for level 1 evidence before they will fund treatments. So they were interested in the question of whether they should continue to fund hip arthroscopy. And they asked the National Institute of Health Research, which is the research and development arm of our health service, to address the question of whether patients with FAI syndrome, if they received hip arthroscopy, did better in terms of clinical and cost effectiveness than if they had what they called best conservative care. And the way that the National Institute of Health Research addressed this was to commission a randomized controlled trial. This process has been quite lengthy and expensive, and in the end, I and my university ended up leading a consortium to do this trial. We called it FASHION, and that was a little bit deliberate because there were people who were involved in the funding of this trial who thought that hip arthroscopy was just a new fashion for orthopedic surgeons. So we played up to that in order to get them to give us the money to test, and we hoped prove the effectiveness of hip arthroscopy. So this was a pragmatic, multi-center, prospective randomized controlled trial. Let me just explain pragmatic. That means that we are not trying to determine whether hip arthroscopy could be effective. We're not trying to determine whether there is some scientific basis to hip arthroscopy. We were asking the question of, in everyday practice, with everyday surgeons looking after average patients, is it effective? That's what's meant by pragmatic. And you will see why that becomes important as the trial develops. So we included patients who were your typical FAI patients. They were all adults, and they had normal sort of criteria for you concluding that they were patients with hip impingement. We felt that they had to have pain, so we were not treating anyone prophylactically. These were all people with symptoms. And the surgeon had to believe that arthroscopy would be effective for the patient. And you'll appreciate that here comes the first point of pragmatism, that we are asking surgeons to use their judgment. In other words, among the patients you see in the clinic, the ones that you would normally offer hip arthroscopy to, they're the ones we want to have in the trial. We excluded people who had evidence of osteoarthritis. We excluded people who had prior deformity or prior surgery, including people who'd had previous arthroscopic or open shape-changing surgery. So these were, in a sense, primary patients with what we might think of as idiopathic impingement. And the patients were divided into two groups for two interventions. One intervention was arthroscopic hip surgery, and the other, best conservative care. Now, arthroscopic hip surgery, I think you all understand, we only specified that the surgeon must perform it arthroscopically, that they could use any position that they chose for the patient, They could use any portals that they chose. They could use any instruments they chose. They had to look around the joint and document what they found. And they had to do shape-changing surgery either on the rim or the femur or both. And they could treat the labrum and the articular cartilage as they saw fit. And at the end, they had to use some method to determine that they had adequately changed the shape, either image intensifier or a dynamic assessment with an arthroscope. The other group of patients had conservative treatment, and we had to develop a protocol for this best conservative care because no one knew really what that meant. And so we developed this and tested it and have published it. We call it personalized hip therapy. It is really a consensus amongst physiotherapists and sports medicine doctors as to how you could best conservatively treat someone with hip impingement. It's not too complicated, it's not too expensive, and that's because it had to be a practical treatment in the public system that we work in. So I don't say it's the best possible conservative care, but it is better than most patients in the National Health Service get, and we thought therefore it's a reasonable estimate of best conservative care. So patients were screened in the clinics of the participating surgeons and then randomized to either hip arthroscopy or best conservative care on a one-to-one basis, and then followed up for 1 year. And the primary outcome was set at 1 year, and the reason for 1 year was that we had to hold the patients in their allocated group for this length of time. So if they were allocated to best conservative care, we needed to persuade them to continue with that until we got to the primary outcome point. And we thought 1 year was the longest that we could hold them in there for. And we did some preliminary work to demonstrate that. And our primary outcome measure at 1 year was the IHOT 33, the longer version of the International Hip Outcome Tool. We plan also to measure clinical results at 2 and 3 years, and then to measure SF36 and EQ5D and cost at each of those points, and to follow patients up longer, both with clinical outcomes and also with prevalence of joint replacement surgery at 5, 10, and even 20 years. But for the purposes of today's presentation, I'll just focus on this 1 year outcome with a clinical measure. The study had to be pretty big. We wanted it to have 90% power so that we could be really confident that if we didn't show a difference, it was because there isn't one. Significance conventionally at 0.05, and the effect size we were interested in was a minimum clinically important difference of 6.1 points on the IHOT 33. And that's previously been demonstrated in this group of patients to be the minimum clinically important difference. And to do that, we needed 344 patients split between the two arms. That's quite a lot of patients. I mean, there are only half that many people sitting in this room at the moment, so that's a large group of patients to gather up. To give you some idea of the timeline, so you can see how a trial like this develops, I started planning it in 2011. We got the first injection of money in 2012 for a feasibility study, and then the big injection of money, about £2 million, in 2014, and we're just now able to report the 1 year results. But we'll continue this trial way out into the 2020s. To get that number of patients in a reasonable length of time, we needed to use 25 centres across the UK, each with, in most cases, 1 and sometimes 2 surgeons. These are the surgeons who participated in the study. They're all people who do a good deal of arthroscopic hip surgery. Most of them had fellowship training in arthroscopic hip surgery, but all of them are tertiary referral centres, so people are sending patients to them for hip arthroscopy. I don't think anyone would say they are all the best arthroscopists in the world, but again, we are saying this is pragmatically what happens in the UK. If you have a hip arthroscopy, it's going to be done by people like this. The physiotherapists who delivered the conservative treatment arm, there were about 60 of them altogether, and we trained them all to deliver that personalised hip therapy in special courses. Altogether, a little over 6,000 patients were looked at in order to screen for eligible patients. And after we had removed those who were not eligible, which was the majority, and those in whom the surgeon thought that arthroscopic surgery was not the appropriate treatment, we ended up with about 650 potentially eligible patients. Now, of those 648 patients, only 351 were randomized. And most of the ones who were not randomized because they declined to take part. About half of them because they wanted to have an operation, and the other half because they didn't want to have an operation. So there was no very clear preference on the part of the patients on average. So these 351 patients were randomized, half to personalized hip therapy, 178, and the other half to arthroscopic surgery. Now, they did mostly stay in their allocated groups, but 8% of the people in the personalized hip therapy group decided during the year that they actually wanted an operation. So they told us, I want to get out of this trial, I want to have surgery. And of course, in a randomized controlled trial, if the patient decides they want to move arms, then you have to let them do so. So we had an 8% crossover rate. So that means that some patients who were due to have conservative treatment ended up having surgery. Now, some of the surgery patients didn't end up getting surgery because other things happened in their lives or they were unwell. So again, there's a bit of a mixture there of patients either getting the treatment that they were allocated to or not. We were able to follow up the vast majority of the patients. 92% were still in close touch with 1 year after their randomization. And there was no difference in follow-up between the two groups, so no bias. Now, because this is a pragmatic trial, and because we are really testing the strategy of sending a patient for surgery or sending them for physiotherapy, the analysis that we've done is an intention to treat analysis. I recognize that some people who were allocated to personalized hip therapy actually chose to have surgery. Some people who were allocated to surgery never got it. But nevertheless, our primary analysis was about the strategy of choosing which way to go, hence an intention to treat analysis. And these are the results. This graph here shows you the IHOT 33 score on the vertical axis, and you can see that the patients were no different in the two groups at the beginning, with an IHOT of the upper 30s, which is quite typical of patients being reported for femoroacetabular impingement surgery. The yellow ones here are those who had surgery, and the blue ones are those who had personalized hip therapy. And you can see that 12 months after randomization, just repeat that, 12 months after randomization, all of them were better. Both groups had improved. But the surgery group have improved substantially more than the personalized hip therapy group. There are some numbers behind this, of course. The raw difference between... Oh, excuse me. What's happened here? The raw difference between the two groups is 9 points on the IHOT scale. We know that there are some potential confounders, and so we do a little adjustment to adjust for those confounders between the two groups, and that reduces the difference a little bit to 6.8 points. So that means the effect of surgery over and above the effect of physiotherapy is on average 6.8 points on the IHOT scale. Now, you'll remember that the minimum clinically important difference was 6.1, so it's more than that, and it's statistically significant as well, with a p-value of less than 0.001. Now, I mentioned to you that 8% of patients had crossed over, and that some patients who were due to have surgery didn't ever get it. And so we also did an analysis of the patients as treated, so a comparison of those who actually had surgery with those who actually had physiotherapy. And if surgery is truly effective, you'd expect the difference here to be bigger. And that's exactly what happened. The adjusted difference is not 6 points now, but 8.2 points. Still statistically significant and getting even more bigger than the minimum clinically important difference. So to conclude, I've told you a little bit about how we ran the trial and some of the challenges in it, because I think that it's interesting for us as orthopedic surgeons to reflect on what it takes to get this level 1 evidence. You've perhaps heard this term before. Soldiers use it to describe the confusion of battle. Well, I think we should think about the fog of clinical trials. I showed you some inclusion criteria. I reckon we could have considerable arguments about whether those were the right inclusion criteria, and certainly we can argue about whether they were properly applied. There were all sorts of difficulties with recruitment, patients who didn't want to take part, and I showed you that 40% of the eligible patients chose not to be randomized. Sometimes patients preferred to have one treatment or the other, and if they didn't get the treatment they were allocated to, that made it very difficult. Surgeons were very bad at violating the protocol. Some of them just didn't do what they were supposed to do, and some of them deliberately undermined the trial in order to do what they fancied doing for their patients. Some patients didn't do what they were supposed to do. They decided halfway through that they actually wanted an operation when they'd agreed to be randomized. There were delays. We were working in a public system which doesn't have enough money, with long waiting lists. And so some of the patients who were allocated to surgery only got the surgery 10 or 11 months after randomization. And of course, we lost some patients to follow-up. Just finishing. So this is the fog of clinical trials, and it can completely obscure any effect that is there. So there has to be a really big effect for us to be able to demonstrate it through this fog. But I hope I've demonstrated to you that we did find a clinically significant effect, and it was statistically significant. And that effect is that in patients with FAI syndrome, hip arthroscopy works. There are not many areas of orthopedic surgery where we have such clarity of evidence. Thank you.